All right, can we get everyone to please take your seat, because the only thing between us and lunch is going to be our next speaker. So let's please get gathered and get in your seats so we can get rolling. Wow, silence. Sound that lunch is getting closer. So I'm guessing we'll have a few people. I saw a lot of people checking their email and stuff that'll trickle in here, but I want to introduce our next speaker. So Caryn and I have not known each other very long. Actually, it's only been a couple of months, and I'm very honored that she is going to come up here and willingly talk to us about technology and healthcare. But I got to tell you why I'm honored about it. So first of all, we've had a leader from arguably one of the most successful retail organizations based here in Fargo, North Dakota with Byron. And then we've had a leader from arguably one of the biggest and most successful financial institutions with Gary. So we all know Sanford. I'm guessing most of us interact with it from a healthcare standpoint, but I get to give my little quick story about it. So many of you know I have a young son. He's 9 years old, and he has diabetes. And we found out 2 years ago, we were actually at Essentia Health at the time in the emergency room, and they quickly diagnosed it and referred us immediately over to Sanford because that's where youth expertise in our community resides when it comes to diabetes. And of course, I'm scared, like every parent would be when you find out something about your child that's just not normal, even if it's, he has a headache, we all frantically worry about it. So it was devastating for us. Because of technology, that Sanford has in place, it has made managing diabetes an unbelievably positive experience for us. So it's still, she hasn't cured it yet. I'm not going to give you that kudos yet, Caryn. But what Sanford has done with technology for us as a patient is unbelievable. We have access through, not just through email, but we have direct access to our physician in multiple ways. We share data from devices and device technology, Bluetooth capabilities with our physician on a daily basis. We have the ability through mobile apps to manage diabetes and to keep track of the information that we need, as well as through, kudos a little bit to us with partnering with you on some of the My Sanford apps and some of the other patient things that are out there. So it truly is an honor to be able to have Sanford here today and Caryn to talk to us about, how do they manage IT and what do they do and what's driving the community and what Sanford's doing with us. So one other note I want to make on this when I bring her up here is I think she's also a testament to us that you don't need to be an IT person out of school to be a leader in technology in our region. So Caryn comes with an extensive background, one that I can't even begin to read about. You can read about it in our agenda here as well. She comes from a nursing background. She comes from actually being someone involved in taking care of patients to now leading a massive organization and providing technology solutions. And so what a perfect person to come up here and talk to us about making a difference. So Caryn, we're honored. Thank you very much. And please come up here and talk to us. Thank you.
Thank you so much. Yes. Boy, these lights are bright up here. That was a great intro, Brad, and definitely stealing some of my thunder as the new leader in this healthcare environment here at Sanford. My talk today, and if you go to the slides there, I preface this talk and will speak to you about technology as well as healthcare and IT coming together and becoming a perfect marriage. Like Brad said, my background is nursing. I have an MBA, and a year and a half ago, I was asked to lead the Fargo region group, and my title here is the CIO of the Fargo region, in our new world at Sanford, and I'll talk a bit about how we've come together with Fargo region, Sioux Falls region, and many, many more regions as we move ahead. It's been a real journey, and I'll talk about who is Sanford, the external pressures that we deal with each and every day, what IT looks like at Sanford, and then I'm looking for questions from you too, so that I can hear back from you and some of the comments and questions that you have. So I don't know how many of you know who this is, and I can't see you very well, but if you would raise your hand, do you know who this guy is? Yeah? He's a hometown boy with roots back in Northwood, North Dakota, Sabin, down the road. This is Kelby Krabanoff. He is our CEO for Sanford, and a very visionary young guy out there really, really making it happen. And you can see that the commitment that he's talking about here in this slide is to be world class. And so when I hear Brad talk about world class with diabetes with children, that's all about Kelby and his best friend and partner, Denny Sanford, coming together to become world class nationally. And think of it, guys, this is right in our backyard. That's pretty cool. The mission, very simple, dedicated to the work of health and healing. This is what we do every day. And the vision, improving, providing exceptional care, and talk about innovation and discovery. Brief history here, and this is a little bit of a busy slide, but I wanted to take you through some of the thoughts and where we've been. I'm going to look over here. It's a little easier for me to see. Taking it from the first bullet point there, Sanford Health and AmeriCare, as we previously were known, merged together just 4 years ago. Since then, we have brought together North Country Regional Hospital in Bemidji, Med Center 1 out in Bismarck. The headquarters is in Sioux Falls. This is a community-owned, not-for-profit organization with a 21-member board of trustees. Lots and lots of integration, largest nonprofit in the area, and serving 8 states and now 3 countries. International in Ghana, Israel, I should say 4 countries, Ghana, Israel, Ireland, and just a couple weeks ago announced presence in China. This is a picture of Denny Sanford, and because of Denny Sanford, we really are where we are today. It started with a gift of $400 million, and this man just keeps on giving to this organization. In fact, shortly we will hear about more and more money that is dedicated and given to the organization of Sanford. And he very much has pet projects, and Brad, you touched on 2 of them. Children and diabetes as 2 of his stalwart projects that he's given to. I guess I'll throw in a third, and that's the third bullet point on this slide. $100 million that he just gave over this past year to really focus on breast cancer. And everything with Denny Sanford goes back to a history of where he's come from. And in this case, Edith Sanford was his mother who had breast cancer. So $100 million to fund the Edith Sanford Breast Cancer Institute and really move forward in finding a cure for more and more of these diseases that we have. Wonderful man. This is the footprint of Sanford as we know it today. The different colors are talking about clinics and hospitals in our network, reaching out to the other states and different countries with affiliates and various different types of relationships that we have with people. Guiding principles always, when we expand out to the different sites, is regardless of ownership. Healthcare services are a community asset. When I listen to Gary and I think about the things that we could be doing with infrastructure and tying that to the guiding principles of Sanford, it is always focused on being local to your community. Health and healing happen best when they occur close to home. So that's one of our guiding principles, and we're not here to take and supplant those small hospitals, but instead help them grow and flourish and be attached to a network so that we can provide services in the small communities in North Dakota Minnesota, South Dakota, and other states. Successful healthcare, both clinically and financially. We are a business like everyone else. Hopefully we're not making stupid decisions that aren't financially sound, but in some cases, even those decisions to bring things closer to the home and community may not be financially the number one, but clinically as very important. Integration is a word that we talk about all the time. Integrating through our IT systems so that we have connection with providers and patients. We're providing quality outcomes to people that we serve. And creating relationships in all these communities as we move ahead. A little bit about our Sanford staff. We have 1,000+ physicians, and I will say, especially for those of you that work with Sanford, it seems like take that times 10, maybe 10,000 different ideas that come from these 1,000 physicians. Lots of energy, lots of good ideas coming from them. 70 different specialty areas. So they all have wants and needs, and guess what? IT is front and center with what they want. 25,000 employees, 160 clinics, 30 hospitals, and oh, by the way, a new one going up next door here by 2017. We have centers of excellence, and with these centers of excellence, I have to laugh at what Byron said. How do you get on the IT list? Every one of these centers of excellence think they should be #1 priority at Sanford, just like your customers too. So no matter if we do heart or cancer, women's, diabetes, trauma, surgery, orthopedics, children's, they all think that they're #1 priority. And so managing what IT can serve to them is absolutely a full-time job every single day. And we do have about 675 IT staff in all of Sanford, and those people are front and center on delivering this up to our customers. A little bit about the Sanford initiatives. I talked about commitment to children. You can see that the Sanford Children's Hospital, even a brand that I'll show you a picture of, replicating that in all of our different communities that makes sense to have a children's hospital or a children's clinic. Also a lot about research, and we think about the data and the storage and the things that we need to think about in the future. Genomics, research, tying those devices at home into capturing that data and storing it and doing something with it. The Sanford project is a really good example of this. Our focus is to find a cure for type 1 diabetes. That's the kind that our young kids have. Advancing healthcare education and talking about integrating technology with the new and fun features in the future. An example here is our Fit Kid app, and download it on your device and give it to your kids and talk about how they can exercise and get involved with healthcare on their own. Sanford Children's Hospital in Sioux Falls opened in March of 2009. 128 beds, pretty huge place, full electronic medical record connectivity, including advanced imaging capabilities. This is a picture of it, and the picture, and purposefully, it is designed as a castle. So when kids come there, they are treated like kings and queens, as well as everyone that works there too. This is a model that is replicated in the different Sanford clinics that are put up throughout the US, and even a model that we'll talk about internationally as appropriate. This is the inside of the Sanford Children's Hospital in Sioux Falls. You can see the fireplace when you walk in. There is a king's chair and a queen's chair to sit in for the kids. And everything is decorated around this theme. You can even see the globe on the floor there to talk about the worldwide expansion of the Children's Clinic and Children's Hospital. The goal here with moving Children's Clinic into a world focus is that the goal is to build more than 5 new facilities over the next decade where pediatric care is needed and unavailable. So the model here that Sanford is partnering with various communities is that you as a community submit an application to be partnered with Sanford to build a children's clinic in your underserved area. You need to cough up 3 to 7 full-time pediatricians along with Sanford and find a building where we can put this up. So Sanford is out soliciting 10 domestic and 10 international locations to do this kind of business. It has to be financially scalable and a good business decision for the area. In our research area, along with what's going on in Sanford and Sioux Falls, I talked about type 1 diabetes, the Sanford Project, a lot of research going on in cancer biology, cardiovascular health. You can see the different areas up there. We have a relationship with a huge research center in La Jolla, California, and that information is traveling across our internet and our VPN pipes to be shared and worked with our team of research statisticians in Sioux Falls. We also are doing a lot with the Office of Native American Health, and that's really close to home for us in Minnesota and North Dakota, especially tying in the Native American population and diabetes. So lots of data coming from lots of research. I'm going to switch gears now away from what Sanford's all about to tell you about the external pressures that we deal with every day in healthcare. So not just specifically Sanford, but all of healthcare organizations. And you can see our favorite friend, Obama, is here front and center, causing a lot of these external pressures. And it goes back in 2009, when President Obama stood up and said, we're going to do something about our cost of healthcare. So I'm going to put on the table that you need to computerize the nation's health records in 5 years. This is going to save billions of dollars, and we're going to make for a different world that we live in. So with this first address in 2009, it has very much turned a place like Sanford and all of our healthcare organizations, as well as our insurance companies, and even to the patients that we serve, to a different venue. This is the curve towards transformed health. Back in 2011, we're capturing data. We're using that data to advance clinical processes as we can use the data and create new treatment methodologies and see what the outcomes are. And eventually, by 2013, where we are today, improving outcomes every day that we gather data, do something with data, and continue to move forward. We've heard the word high tech. High tech, very close to home here in North Dakota. Looking at pre-2009, where we had no electronic records, to 2014, next year, expecting that we'll have widespread adoption and meaningful use within our electronic health records. And hold on to that word meaningful use, because I'm going to give you a little education about that and what it means to each and every one of us. So going back, Medicare and what was formerly Sioux Valley came together, and we both had electronic records. When Medicare and Sanford joined 4 years ago, we being Medicare in Fargo, the recipient of a tool called Epic. It is the #1 electronic health record in the United States, and I can say that we felt like it was a gift, that we are working together, we are combining our electronic records, and indeed, we are there for meeting widespread adoption and creating a meaningful use record that we can hold up and be accountable for. This record is patient-centric, and Brad, I'm going to again go back to you. Because of this ability with Epic, we can do things like have patients at home downloading their blood sugar information and uploading it to our systems. It is patient-centric, delivering information, creating that bidirectional interface between patients and their providers. It will result in better outcomes, safer treatment, faster delivery of information, and more efficient coding and billing. And I truly think that this is something that we're going to see. Each and every day we struggle with this as the systems are coming together, and we're still in the process of interfacing other disparate systems into our Epic system. But eventually we're going to see the fruits of our labor bear good things. This is a little bit of a busy slide, but the high-tech vision and again, going back to Obama's speech in 2009 and how this has played out throughout the states that we work with, we have seen regional extension centers, organizations that have popped up in North Dakota and Minnesota that are helping each and every organization adopt the use of electronic records. This involves workforce training and just helping to strategize small community areas, and even Sanford, in getting to the adoption of an electronic record. Throw on top of that external influences from Medicare and Medicaid with their initiatives and penalties, and we get to the word called meaningful use. Not only do you have to have an electronic record in place, but you have to have people that use it meaningfully. And that is how you are going to bring money back into your organization while you've spent millions and millions of dollars getting towards an electronic record. Down at the bottom of the slide, then, you have states that are now getting part of this, states that are creating grants so that they are involved in the exchange of health information through all the different organizations within the state. Take that one step further, you have national involvement. So national organizations that are trying to hook states together so that we can all share our very protected and very private patient information. So everybody's got skin in the game in this. And the next few slides are talking about how we actually become meaningful users and how you actually get paid for having an electronic record that is showing meaningful use. So each of these slides will talk about the different objectives and measurements that we are held accountable for. And I'll pick on a couple of these. The very first one, CPOE, and in the healthcare world, this is a name we toss out all the time. It means that our physicians are actually using our computer systems to enter orders. Computer-assisted order entry by clinicians. So as one of our measurements to show that we are meaningful users within an organization that has an electronic record that is a meaningful use electronic record, i.e. EPIC, we have to have, for stage 1, greater than 30% of patients with more than one CPOE med order in all of our clinics, and in our hospitals, a similar measure. So when you think about the data and the infrastructure and all the IT stuff that go on behind achieving just that one metric, think about what you need to have in place. An electronic record, you've got to have trained physicians, you've got to have the ability to measure it, and that's just one of the things that we're held accountable for. That was phase 1, meaningful use phase 1. Phase 2 steps up the metric, so no longer is it 30%, it's 80%. And that's how you're going to achieve your goals. E-prescription, there's another one down there, a couple rows down. Greater than 40% of the prescriptions will be done via e-prescription. So e-prescription means that you have to have systems in place so a doc can sit at a PC, select the med that he wants me to have, and it is e-prescribed through our electronic systems, and our pharmacies are receiving that on their end. All the allergy checking, all the drug-to-drug interactions are happening, and that process is happening for greater than 40% of our prescriptions. That indeed is part of what we're held accountable for every year. Med lists, med allergies, vital signs. So for those of you that are thinking of this as a patient, I think I would start to feel really good that places like Sanford must have this in place to be meaningful users and to be getting money back from this whole initiative of getting us to an electronic record by 2014. We're capturing smoking indicators. We're doing decision support metrics, quality reporting that is not only reported within the walls of Sanford, but out throughout the whole nation about how we are achieving outcomes for our patients. We have an e-health summary, so that every time you are seen at a clinic or a hospital, we have a requirement to send home or electronically distribute to you an after-visit summary. That may be coming to you in paper or through one of our apps that we talk about, and I'll show you a few slides about that, my Sanford chart. Improving care condition. Another of the things that we're working on is we must be able to exchange information with other providers. Now, by using Epic itself, the community of Epic users can easily exchange information from hospital to hospital, clinic to clinic within the product, as long as you have the patient agreeing that we can do that for them. Take that one step further, we now have to be able to exchange to those non-Epic users as well as Epic users. So here's where our states get involved with creating HIEs, health information exchanges, so that a patient that is seen even in a nursing home can easily exchange information with Sanford as the patient is brought into the Sanford community as an inpatient or sent home back to the nursing home from Sanford. So this, again, is another metric that we must achieve. Privacy and security are utmost in everything that we do, and we have to make sure that we're protecting patient information and going through lots of security and privacy checks every single year to make sure that we're keeping this information safe. Now, how do we get reimbursed for all of this work? This is, again, a very busy slide, but my point of showing you this is that because we have people like Obama leading the charge for Medicare and Medicaid reimbursement, we have incentives. I call it the pot of money that's out there that says if you achieve these goals, you indeed will get reimbursed X number of dollars for every single provider that you have or every single organization you have if you're either a hospital or an EP, an eligible provider. So here's our maximum Medicare incentives for our EPs in a non-shortage area or in a metropolitan area. You can see the color coding. It's not really important to look at all of the different details here, but there are different stages. So you're playing a game to achieve the goals at the different stages. You want to be there in the green to say, get out there, do it quickly, because that's when you get the most incentive money. And you have to achieve both a stage 1 and a stage 2 by the various dates. So the way that this was packaged up from the Obama administration, they incented organizations like Sanford to get out there, do the things you need to do it early, and make sure that you can get out and get the money back to your organization. So all said and done, you can see the money that is on the table, and I'm happy to say that Sanford is out there achieving in the green where we need to go, and bringing that money back into our organization so we can continue to invest in the other things that we need to do. A little bit different chart for other types of hospitals that we work with. So not only is there an incentive for our clinic providers, but a whole different incentive for all the hospitals that we have. And if you remember back, Sanford has about 30 hospitals. Some of them are what we call PPS hospitals, the bigger ones. And then there's a whole nother chart for our critical access hospitals. So think of this craziness that we work through every single day with the governmental external influences of how we need to achieve what's right for patient care every single day. North Dakota then has done a lot of work itself on creating its own health information technology, or HIE, system. I talked about this briefly, but North Dakota, I will say, is one of the leading states in bringing together and creating the vision of how we're going to exchange information with all the different players within North Dakota, or the North Dakota HIE. So again, back to 2009, the state of North Dakota then created a Health Information Technology Advisory Committee, also called HITECH. And this group has been out there on a mission to say, how are we going to take the incentives and the expectations from the government and help our different bodies in the state of North Dakota to exchange information? They have purchased or created a relationship with a vendor called Orion Health. And Orion Health now is the focal point for all of the different players in North Dakota to send information and exchange information back and forth. So the vision I talked to you before about the nursing home can tie into the HIE and get information that Sanford actually sent to the Orion system for the state of North Dakota. HIE with phases is listed here. You can see phase 1 just starting to harvest, I'll put it that way, on edge servers in the state, information from all of its constituents, big hospitals as well as other organizations. Creating more and more, working with payers and sharing information with other trading partners as we put this vision together. This is very much in the infancy stages. Orion has been selected as the vendor of choice, and currently now organizations like Sanford, up in that first box, are starting to send data to Orion Health. So I'm going to switch gears now and talk to you a little bit more about Sanford Information Technology. Again, goals. We are about perfecting the patient experience. And it is interesting, Brad talked to you about my background being a nurse first. This is something I can live and breathe and eat every single day. It is about patient care. It is about being the advocate for the people that treat our patients. It's for being the advocate of customers, like each and every one of us, and our kids that we think about every day. Facilitating excellence, improving efficiency, supporting clinical decision-making with data, advancing research, and improving communication. And central to all of that is our IT systems. Some of our major priorities, or getting on the IT list, implementing Epic at every single site that we touch. I would say we're about 2/3 to 3/4 done with implementing the foundation of Epic. But if anyone knows any of these vendors we work with, you're never done. You continue to refine and optimize and add all the new bells and whistles. So drinking the Kool-Aid with Epic, and this will be a forever thing as we continue to march forward. Lawson is also our vendor of choice at working with all of our financial systems. We're big on doing our Microsoft AD conversion and becoming a Microsoft shop throughout all of our sites. You can see the Office product conversion as well. And the bottom bullet, not easy to say, bringing consistency and standardization to all the platforms and infrastructure that we deal with. So when you think about where we've come here in the Fargo region as compared to 4 years ago, we were very autonomous doing our own thing. As you become one with the Sioux Falls organization, we are now a different corporation together. We deal with some of the things that you talked about today, workforce that is virtual, workforce that may be in different states, and how do we now interact with one another? How do we standardize? How do we assure that our health care is provided in a standard method, irregardless if you're in Sioux Falls or in Bemidji or in Bismarck? This is the tough work, and this is the work where IT and our operational leaders need to partner. Some of our goals to support our business strategies, and it is all about the business. It is about timely access to clinical information, patient safety, patient flow, being very smart in what we're doing, patient-centric systems, improving our employee and our physician satisfaction, security, facilitating, teaching, and research. I love this picture of Epic, and just 3 words. It is an inpatient system, it is an outpatient system, it is an every patient system. Partnering with Epic, and I don't know if you know much about them, they are a privately held company out of Wisconsin. They have a campus that is kind of like our Microsoft campus here in Fargo, on steroids times about 10. It is a beautiful campus, a beautiful organization, and it's been a great trip. Like I said, it's been a gift to be able to implement Epic and now jump on the bandwagon and work with Epic, as we will continue to do for many years. These are just some of the other companies or healthcare organizations in the US that are also Epic clients. So they are taking the US by storm. I think 2 years ago, 23% of every healthcare encounter was done with an Epic record. And as of last year, that now has grown to be more in the 40 percentile. So they really are a company to watch and be involved with. Right here in the Fargo-Moorhead area, Essentia Health, All True up in Grand Forks, and Sanford are all working with the Epic system. Some of the additional pressures that we're working with every single day, again, external, some of them internal. ICD-10, has anyone heard that before? It's tough for me to see your hands. A few of you are hearing about ICD-10. So when you are seen as a patient at Sanford, in order to get a bill, we have coders, again, remotely. Gary, think about all of our coders that we need out there. Coders that are sitting at home, looking at the documentation that was collected by nurses and physicians for that episode of care, and tying what they did to a code. The code creates a charge, hence a bill, and that's how this all works. So in October of next year, October of 2014, what we currently know as ICD-9 coding system will now change to ICD-10. To put that in perspective, we today have about 5,000 different codes in ICD-9. That is extrapolated to about 70,000 codes in ICD-10. So when you think about that, and all of you have put your technical minds on, a coder today can be pretty good knowing some of the codes, and they've only got 5,000 to deal with. The coder of tomorrow needs to now know 70,000. We now have systems called computer-assisted coding that sit in the middle of that whole process. Computer-assisted coding looks at documentation, prompts you for some of the codes that you need. This is going to probably, next to getting to electronic records, this is going to turn not only Sanford, but our insurance companies, Medicare, Medicaid, really on their heels as we now count down to October of 2014 and moving to ICD-10. At Sanford, we will put in our computer-assisted coding systems in place in January of 2014 so that our coders can now get used to using those systems. But when you think about where do we need to be getting our workforce geared up, and like I said, these people can sit anywhere, but we need to deliver them the technology to be able to do their work. So that's another pressure that, oh, by the way, we have on our plate. Rtls, everybody know what Rtls is? No? No hands on that one? Few hands. So real-time locating systems. Right here in town, we have a wonderful vendor called Intelligent Insights. Intelligent Insights is an organization that is first and foremost in Rtls, and they're working very closely with healthcare. Just a month or so ago, Sanford and Intelligent Insights signed a contract and are moving ahead with implementing Rtls technology throughout Sanford. Now, what does that mean to each and every one of us? We will be tagging assets, and assets will be pieces of equipment. They will also be patients, and they will also be staff. So think about the data that you can capture, and all of us have phones. Our phones have GPS on them. Now we have GPS systems tied to any piece of equipment and any person that works for us and any patient that comes in the door. So think of the things that you can do with an Rtls system that can help us look at our workflow process and try to perfect what we're doing and optimize that patient-provider interaction. So I'll give you an example. We're going to open a brand new clinic here in Moorhead next spring, in fact, about 4 months from now. And our goal is to have Rtls working, not only for help me find the wheelchair, but also to do creative things like self-rooming. How many of you have gone to a clinic and you check in at the desk and they tell you to go sit down and you wait and you wait and you wait and you wonder and, you know, I need to get into the physician and all of that is going on. So turn that around. We know who you are when you walk in the door. We know that rooms are open. We know where the nurses are. We know where physicians are. We can tie that all together and create a better patient experience knowing this data and capturing this data. Looking at monitors up on the wall that tell us where everything is, and we can provide better patient care. That's just one example of things that we'll be able to do with Rtls technology. Some other really neat things that you can do with Rtls, and I just have to laugh every single day. Each week at our President Council, We approve capital investments. And some of the things that RTLS can help you with is to avoid capital investments. They can tell us that you have plenty of wheelchairs. You don't have to buy more wheelchairs. Or you don't have to buy that additional expensive bed because you can look at the utilization of the assets that you have. So I talked about we're moving forward with building a new hospital that will open in 2017. We want our RTLS technology in place to look at and manage assets so that we don't have to buy everything new for the new house. Instead, we can take a look at our utilization and say, oh, we only need 1,000 wheelchairs downtown. We can take another 1,000 out here and we don't have to pay any more money. So RTLS is very exciting, brand new. Our first sites will go live in 2014 with asset tracking in our major medical center in Fargo and Sioux Falls, and then looking at patient workflow in our Moorhead Clinic and expanding from that point forward. Next bullet, we talk about standardization of systems. And you can imagine if I put 4 of you in a room and you were radiologists and you came from Fargo, Sioux Falls, Bemidji, and Bismarck, and you are all working with different PACS systems. PACS is Picture Archive Communication System. So our radiologists sit at cockpits every day. And the pictures that are taken when you go have an x-ray are all digital. They can sit anywhere as long as they have the bandwidth and the infrastructure that we can provide them. Well, today we have 4 different PACS systems. Every single organization picked a different one. Our challenge moving ahead is to standardize this. And as you can imagine, a PACS system itself is multi-million dollars. But think of the power and think of the things you could do when you standardize on the product and you provide that infrastructure no matter where they live and where they work. In fact, some organizations are doing creative things, like in Australia. We've had small hospitals that outsource their night reading to Australia. Across the other side of the world, it's daytime, so you can get radiologists that will read films for small hospitals in the US because of the night and day difference. So think global. Think of what you can do when you've got the power of the infrastructure behind you and tools like this. Cardiology is the same way, doing really, really creative things, a ton of bandwidth with saving videos, image, both still and video pictures with cardiology. HRIS is our HR information systems. Obviously, we need to pay our 25,000 people. We need to track all of the inventory and everything that goes along with the HR and financial systems that we have in our organization. Again, standardizing on what we do from a Sanford perspective. We are also looking at infrastructure consolidation. With the 4 major hubs that I talked about, Sioux Falls, Fargo, Bemidji, and Bismarck, today we have 6 data centers. You don't need 6 data centers anymore. You need 2 data centers. You need a primary and a secondary for disaster recovery. We're also looking at cloud computing. Kind of nervous about it, especially when we talk about patient information. And so we're looking at thinking of how we may investigate that more. Optimization of current systems, like I said, Epic never ends. Lawson never ends. You select a vendor and you continue to optimize. And then my bottom couple of bullets of additional pressure, I talked about meaningful use and achieving those goals. And some of the other alphabet soup you have here, HISPs and HIT and high tech and eHealthy Way are all different organizations and different methodologies that Sanford must play with to make sure that we are exchanging information like we are expected to do to meet meaningful use and other objectives from the government. We also have a huge area of our business called Intranet, Internet, and various social media strategies. I think it was Byron that talked about Twittering and the different events, and I, just like you, my kids don't talk to me unless it's Twitter nowadays, and is it Snapchat? That's the other one. It's the only way to talk to them. So a little bit on our mobile web. This is the Sanford App, and we have internal development as well as working with some of you in the room that is now available on smartphone and mobile devices. Go to the App Store, download it, and we are we are doing some very creative things in this space, and it seems like it's never enough. So we've started with a small suite of applications or functionality on this app: finding a doctor, locating clinics, we're monitoring wait time, and then we do have a linkage to the My Sanford chart, where you can actually view your own personal health record, schedule appointments, get your prescriptions renewed, and get answers, that two-way interaction with your medical provider. The app is available on iPad, iPhone, Android devices, and you can see what it looks like here. The Find a Doctor app is really very neat. By region, by specialty, you can get directions, you can get phone numbers, you can get to the map to tell you where to go and who you want to see. The wait times are specific to places like our walk-in clinic and emergency room areas. So you can pull up that site, it can drive you to the map and tell you what the wait times are. My Sanford chart is probably our diamond in the rough. And this is actually a part of the Epic system, but we are embedding it into the My Sanford app so that it all comes together in one nice package. And like I said, these are some of the major reasons of why you would engage in and use My Sanford chart. This is a free thing, and as long as you're a patient at Sanford, you will have information in your My Sanford chart to take along with you. This is where you sign up. You can do it right online. And here's some little apps within, or functionality within the app to show you what you can do. This is a picture of what your health summary will look like online. And again, you can do it on a computer or even on your phone. You can find out what your last immunization record was, the last time you were in, your vital signs. You can look for test results every time you have any lab draws done, or we're moving into radiology results as well being online for you. Obviously, the big red in the top, don't use this in case of emergency, but you can get medical advice. You can email your provider, it's all protected email through the app itself, and send something into your physician, get advice back. In fact, when we get to meaningful use stage 2, part of our incentives are based on that physician-provider interaction. So we must show that two-way information going back and forth and be able to track that. You can see your upcoming appointments. You can request an appointment online. You can request a prescription renewal. And if you're a mom or a dad of younger kids, or even taking care of your parents, you can request and gain access to your family members' records as a proxy. So I have 3 teenage kids, and I have all of their information right on my phone. I get alerts to their appointments, I get all their results, so that I can be managing their health care as well as my own. So I'm going to close, and I'm looking for your questions out there. Hopefully I've given you a smidgen of healthcare and IT, the great marriage. It absolutely has become a central focus for Sanford. We have the CIOs sitting at the table with all of the operational leaders, making decisions about where we need to go, what we need to do. And like I tell them, and all of you, there's really nothing in healthcare we can do anymore without the foundation of IT being in place. We've got a key to we've got to mentor our staff to continue to understand the business of healthcare so that they can bridge the needs of clinicians in IT. And I continue to drive that home, and I'll go back to myself again. Being a nurse and surrounded by the IT techies has been a great marriage of learning from the technical people what we can do, the technical people learning from the clinical people of what the expectations and what the dreams and what the ideas are out there. So the more we can mentor our staff to be able to have that business knowledge and that technical knowledge, we will all become much, much stronger. And again, having IT at the executive table to help make decisions is very key to this marriage. And with that, I will open it up to any and all questions you guys have. And I can't see ya.
Once again, I will bring the mic to you. This isn't just a Gary thing. So come on, any questions for Caryn?
Must have questions.
Amazing. You just talked about Obama without saying the Obamacare word. Nobody has a question about that. Mobile apps, cloud technology. Wow, we have educated everybody today.
Did any of this surprise you? What's going on in healthcare?
I'll ask a question.
Yes, go ahead.
I had read an article in the forum, and I thought it was maybe a year ago, 18 months ago, and it talked about the normal turnover you have with employees, and given the amount of people you employ, I can imagine the technology behind recruiting employees, screening employees, hiring employees, managing them. That's got to be pretty complicated. Would you care to comment on it at all? Give us some background.
Oh, absolutely. I'm trying to think of our statistics. We have, just in the Fargo region, every month we orient between 100 and 150 new employees. So extrapolate that, that's just for Fargo. Sioux Falls does similar. So let's say probably 300 new employees every month. So when you think about what goes into that with the applications online, which we do have an online app that was homegrown, the selection process, the interview process, everything else that goes into that, lots and lots of time and money, and like you said, infrastructure that needs to be in place to do that from an IT perspective too. Once you get them in the door, think of their education process and the time it takes to get fully functional employees, be it IT employees or be it clinicians that are serving our patients. So absolutely, it's a huge part of our business. On, guys. Yes. Boy. You know, I can see reduced healthcare costs. I can see where we've started reducing healthcare costs several years ago, in fact, with implementing IT solutions and taking advantage and expecting our operational people to drive some of the dollars out of the organization because of IT investments. So I'll just pick on a few. The PACS system, like I talked about. In the old days, we used to process film, pieces of film that had to be stored, that had to be processed at a cost of between $5 and $10 a piece of film. We now have systems like MRI machines that are 64 slice MRI machines, meaning they can take 64 pictures per minute and store that information electronically. If we had to do that in the old days, that is just cost prohibitive, and then you've got to store it. So even though the PACS investment is huge, we're starting to see that that is paying off in the long run, as well as being able to read anytime, anywhere, and not be bound to that. We've done document imaging systems so that we're taking an image of that piece of paper while we still have paper and tying that into electronic records rather than storing tons of paper in warehouses. The whole transcription world, that is something else that we made the news for several years ago as we outsourced our transcription services here in Fargo overseas. And Gary, where was our bandwidth in those days? I mean, that's kind of where we were at. We needed bandwidth in North Dakota. Instead, we ended up going overseas because it was cheaper to do it and truly a business decision. Transcription, in my mind, goes by the wayside. We're now looking at dragon voice recognition systems that have made market improvements so that our providers can easily dictate, it turns into text, and away we go. So again, driving that cost of having a whole transcription system there and paying the people to do that kind of work and causing delays in healthcare. So those are just really 3 examples of using technology to drive costs out of our organization. And I do think it's happening. Probably not as fast as some of us like, but absolutely there.
With challenging labor markets, what are organizations like you doing, or are you looking at outsourcing to help fill that gap with some of your IT needs?
We're in a pretty fortunate situation right now where IT staff are pretty solidly in place. I'm kind of hesitating because the things that I deal with every day, particularly in the Fargo region, are that you guys want our staff too. And so the market that we constantly measure up against are that these people are at a premium, and if we don't pay them well, we will lose them. So we need to keep our employees happy. We need to learn to work virtually, because when we have pockets of IT people in Sioux Falls and in Bismarck and in Bemidji and Fargo, if you can work in virtual teams and share the work that we need to do, we don't need as many of them when you move ahead and get to a standardized organization. So it's a real balance, and it's something that is probably the #1 thing that I deal with every day right now. And I think that we'll continue to be challenged, especially by the other things that you guys talked about. I mean, the whole world is IT, and you're going to want these people that know technology and know business and can make a difference in the world working for each of your companies as well. I can't see you very well, so go ahead.
Caryn, good morning.
Yes.
3-part question for you.
Yes.
You use the acronym Microsoft AD. Could you define that? Number 2, are you seeing the potential for mobile technology for medical professionals to do the entry? I'm assuming that most of their records entry is through permanently mounted stations or workstations. Are you seeing opportunities for mobile IT as the professionals move around working with patients? And then 3rd, if you had a pie chart, and that pie chart, there were 2 of them. One allocates your future dollars for capital investments. The other allocates future time for your staff. Describe the pieces of pie in each pie chart, time and dollars, in terms of medical records, mobile IT, new devices that connect. Give us a view of how you're spending your time and money, and what do you see the future, maybe beyond what you comment today, what you're implementing. What do you see as being available in the industry?
Wow, he's tough, huh? Okay, Microsoft AD is Active Directory. That was the easy one. Second one, mobile. Are we doing mobile? You bet we're doing mobile. In fact, last year we invested in 150 iPads so that our providers could be using them in our hospital and clinic settings to walk around and work with Epic, starting as a view only, but now migrating more into an input device for them. Along with that, we have to be along with our partner Epic, because Epic also creates a desktop version of Epic, a different product that actually sits on the iPad, and yet a different product that sits on your mobile phone. So being in concert with Epic, we want to provide what the provider needs at the point of care to do the work that they need to do. So mobile devices, absolutely, and in fact, we have mobile devices on carts in our hospital setting as well. So they're not tethered to the bedside, but rather can move around and do what they need to do. Been very successful, and we look for more and more of that. In fact, the vision of the future, in fact, it's happening today with products like my Sanford chart and what Epic is bringing to the table. Our providers can be sitting at a soccer game and get an email from a patient asking for something and responding right back to that patient anytime, anywhere. So definitely mobile's in our future. The other thing I'll add to mobile in our future is the interaction of the patient as a patient comes in to a clinic, or even before they get to the clinic, sending that patient something like a questionnaire to respond to before they get to their appointment. How many times do you go sit in the waiting room and somebody hands you a piece of paper and you fill out something, and I look at that and I look at it myself and say, you should know all this about me already. Don't be asking me those questions. So now we can deliver through the power of my chart, knowing that I have an annual physical. These are the things I want updated. I can do it right online. It comes right into the record. So the interaction should be, oh, I see that you've just updated that information. That's great. Now let's talk about the next thing. So mobile definitely is in our future. Then the last one, pie charts. Where do we see us going in the future and spending time and money? And you specific to my staff or to the organization? My staff, time and money. I'm not quite sure how to answer that. Time and money on my staff. First of all, the staff is very much, when I look at our pie chart, I would say 75% of our staff is attached to Epic in some form or fashion. So in working with a major vendor like that, your time and money are all around implementing new, optimizing new, taking the new products from Epic and getting it out there and doing that. We do have a small development area that is very active and building the new cool things that you can't do in your major monolithic vendors like Epic and Lawson. And they are creating those little bridge widgets and also doing all the stuff with our internet and intranet technology to get us to where we need to be. I'm not quite sure I hit on all that. Yes? Okay.
Hey, Caryn, here in the back. 2 quick questions this way.
All right.
Hello,
there we
hi
go.
there.
Hi.
So to add on to the mobility question, a lot of the customers and clients that we work with here in North Dakota are trying to figure out the bring your own device phenomenon, and even some in the provider systems as well. I'd like to get your thoughts on what Sanford's take is that from a clinician standpoint, like you'd said, bringing in your own purchasing iPads, what have you. So the whole topic of bring your own device. And then secondly, on a different note, it'd be interesting to hear about how in IT and across Sanford as a whole, how do you guys employ or utilize analytics and to do your jobs, make your jobs easier, improve care, and so forth? Thank you.
You bet. Bring your own device. Yes, we absolutely have to be there. And while I say that, we have to make sure that every bit of information, particularly patient information, is protected. So I know my best buddy is in the back there, Todd Morgan, my technology director. We work with providers when they bring their own device to work. We work with customers as they bring their own devices to work. And the future is that we need to support that. The iPads that I talked about purchasing about a year ago, we set them up so that they were devices that were not tied to anybody in particular. So the negative side of that is while I'm a provider rounding on patients and seeing all of my information on Epic, I can't switch over to my email easily. There is a way you can do it, but if I brought my own device and I got to Epic and I also got all of the things that I wanted to get at, it definitely would be a better experience for me. So yes, indeed, we need to do that. Data analytics, huge business for us, and lots of strategies on the table today about getting to a truly functional data warehouse. Partnering with Epic, because all of our clinical information is coming from Epic, and being probably one of their first, if you want to call it a beta or alpha site, with Epic creating a data warehouse and then pulling in other information like from our Lawson systems, our physician comp systems, other systems, so that we can pull it all together. There's a lot of analytics right innate to Epic, but the power of pulling other systems together makes it even more strong. And we'll see lots of that. In fact, what did I read the other day? The sexiest job in the world is those data analytics people or those data statisticians or whatever. That's the hot job of the future.
Caryn, you did a great job today. I appreciate your presentation.
You bet.
Very thankful for your organization in our community and what you've done over the years. What is the benefit to this ICD-10 coding going from 5,000 to 70,000 different codes? And my other question is on innovation. You talked a little bit about the transition of healthcare and innovation, and when I work with customers, I see that innovation being driven from the private market. But in regards to Obamacare, is the government the one that's being or driving the innovation? Or is it coming from the private sector like yourself, the organizations you partner with? Or is this Obamacare more of an obstacle to the innovation?
Boy, great, tough questions. I forgot the first one already. What was that about? Coding, yeah, what is the point? Good question. I can only read into that more specific coding is going to provide us better data to tie to outcomes and be more specific to patient care needs. So let me give you an example. Today when you code a broken bone, it's a broken femur, and that's about as specific as it gets. You might get left or right, and that's it. So the future of codes, particularly in orthopedics, gives you a lot more specificity. And there may be 50 codes now that means you have a broken right femur, and it might be due to X, Y, Z, you name it. If you've got that data, you can then do a lot more with it when it comes to patient outcomes and providing better care. So I believe that that's why we're doing what we're doing and where we're going with ICD-10. Of course, tying to payers as well. Innovation. You know, I like to think that the private sector really helped the Obama administration understand where we need to go. And with his support, we're all now getting on the bandwagon and getting there. And I'll say that because places like Americare and Sioux Valley and Sioux Falls, we were doing electronic records before we had to. We recognized the need for involving information technology and doing things for healthcare before the government influenced us to get there. Now, one could always argue the government influenced us by paying us a certain way, but we have very smart people in the private sector knowing that we can be more productive with the things that we do with technology every day. So I think it's a marriage, it's a partnership, and we're all getting there together. I bet you guys are hungry. Oh, okay. Anybody else? Thank you so much. Appreciate it. Thanks, Fred. You bet.
All right, so first of all, Caryn, I got to correct you on one small little thing there. I think that Mr. Corwin, is he still in the room or did he sneak out? I think the answer he was looking for on how do you do the analytics was, well, IBM, of course. So, at any rate, I liked your answer much better. Okay, seriously, on a sincere note, Caryn, thank you very much. The services that Sanford provides to our community and the job that you're doing, it really is an honor for you to come up here and speak to us and talk to us about it. We are all the benefactors of it. So I just want to say thank you one more time. Okay, so on a little brighter note, I did see a couple of correlations. So Caryn, you and I are under the exact same stresses every day because much like you having Obama telling you what you have to do, every Monday morning I have Carlsruhe telling me what I have to do. So it's very similar, the correlation of stress that we have. Okay, that's seriously, you guys really want to eat, don't you? Okay, all right, so we are going to cut here for lunch in just a minute, and there's a few ground rules here. This is not going to be like the Miskovich family Thanksgiving. We are going to cordially go out and get in the buffet line, grab our meal, and then sit down and have very nice discussions, work-related, with all of our vendors. And then when we're done, instead of, napping on the couch, we're going to go and visit with our vendors. We'll have plenty of time to please visit them in their booths in the room next door. And then we're going to gather in our breakout sessions at 1 o'clock. Okay, and there's plenty of time. There's plenty of food. We planned for 170. We got about half that. So there'll be plenty of food for everyone, so please take your time going through the line. Okay, a couple of notes on this afternoon's presentations. You have in the booklet, I'm sure you all have them, and if not, grab one out there. They will describe each and every session, what the topics are, and the speakers. If you are not sure or questioning where it might be a good fit, please see one of the Network Center employees or visit the vendors next door about what their topics are going to be. A little note on the one that you'll see here in this core room, we've kind of designed this talk track to be mobile, cloud, and then also the non-technical resources. It's really going to appeal more to that type of a user. So if you have questions, see somebody else about it. Otherwise, this would be a good area just for the and Brett's just glaring over there, all excited to present. So, yeah, it will be. It'll be a great session. Okay, that being said, once again, we're not going to gather back here. You're going to go right to the breakouts. We will gather back here at 3:50. So when the final breakouts are over, come back into the room. We're going to have prizes to give away. We'll have a very short closing, and then we will partake in some beverages and a social. So with that being said, please enjoy lunch, and we will see you at the breakouts at 1 o'clock.